Thank you, Mr. Chairpersons, and thank you, Srinivas, for asking me to give this talk. This is a difficult topic that he has given to me. Is there ever any right treatment for any given case? I think we have to tailor it to the patient. Before we go on, next slide, please. So the topic was selection of the correct treatment. I don't know about that, but let's go on. So, what is the epidemiology? We are talking about unruptured aneurysms. So, it's about, in different parts of India, the incidence is different. In Kerala, for instance, it is supposed to be much higher. 0.75 to 10% is the variation that we get in different parts of India in unruptured aneurysms in normal individuals. And there have been various studies to determine how many of these unruptured aneurysms go on to rupture. So we have the earliest was the ISUI, which was in 2003. Then there are two Japanese studies, a small aneurysm one and the UCAS, and then FIGIN. So in the first study, which was the ISUI study, they thought it was the size of the aneurysm which was important. And they also added location, the posterior circulation aneurysms being more prone to bleed. But surprisingly, the incidence of hemorrhage in the anterior circulation aneurysms was very low, 0.5% to 1%. And so in the Japanese study, they studied only small aneurysms, and they added to anterior and posterior circulation aneurysms the finding that age, as patients grow older, the risk of hemorrhage is higher, but even young patients do bleed. Hypertension was thought to be a common cause, and if there were multiple aneurysms, then these patients were prone to bleed. So that is to say, these are the patients who should be treated. In UCAS 12, they added if there was a daughter sac, and in female sex, the incidence of hemorrhage was higher. And FIGIN added smoking. And now we all know that most of our patients who are smokers come back with either rebleeds or enlargement of the aneurysm. Yes, FIGIN also added alcohol. And they showed that patients who were taking alcohol were prone to infection, prone to hemorrhage. This is the biggest cohort of Finnish patients. The advantage of Finland is that these patients don't travel. So they are a captive population. And therefore they were able to make longitudinal studies going on for these patients were recruited from 56 to 78, but were analyzed in 11-12. And the conclusion was cigarette smoking is of course important. Younger the patient, less chance; older the patient, higher risk of hemorrhage. And size and location, 0 to 7 mm, the incidence of hemorrhage is very low. 7 to 12 mm, the incidence is about 7%, less than 5% in fact. The incidence of hemorrhage is less than 5%. And when the aneurysm is more than 12 mm, the incidence is about 10%. And when you go to giant aneurysm, the incidence is about 40%. So size is thought to be very important. And then we have the phases score, where they added hypertension, tobacco smoking, alcohol, and even some drugs. So what are the risk factors for rupture of aneurysm? There are some aneurysm-related factors and there are some patient-related factors. So the aneurysm-related factors are increased aneurysm size morphology, size more than 7 mm, irregular shape, daughter sac, direction of blood flow. If the blood flow is straight into the aneurysm, then there is a risk of hemorrhage. A symptomatic aneurysm, of course, needs to be treated. Aneurysm growth on follow-up imaging. So what is necessary for all these patients where we say we won't do anything and an aneurysm is discovered is to follow up. So we follow up either on CTA, on MRA, what frequency, usually first time after 6 months, then after 1 year, and then every year. And the other criterion is if there is a previous hemorrhage from another aneurysm. Amongst the patient-related factors, female gender, cigarette smoking, hypertension, age, family history, alcohol, binge alcohol drinking, and symptomimetic drugs. So in the Japanese study, again very large study, 5,720 patients, they found that the basilar tip, in short, posterior circulation aneurysms, basilar tip, vertebrobasilar, PCOM, have a higher risk. And they added ACOM. Even the ACOM aneurysms, anterocommunicating artery aneurysms, are prone to rebleed. MCA, comparatively much less prone to rebleed, or to bleed. This study was carried out in Trivandrum again, where they seem to have a very high number of patients, and both at the Trivandrum Medical College and across the road, Sri Chitra, they used to get a lot of patients with subarachnoid hemorrhage, and part of this was because of the work done by Dr. Sambasivan in making the local population aware of subarachnoid hemorrhage. Until then, it was just passed off as headache. And what they found was there were more males than females. Usually, in most locations, females are more prone to get subarachnoid hemorrhage from aneurysms. And many of the patients had hypertension. Diabetes were not so important, surprisingly. And of course, family history and smoking and alcohol were very important. So when we have whether to treat or not, we have to analyze patient and aneurysm related factors. Is the aneurysm suitable for surgery or for endovascular? And what is the expected recovery time following the treatment? And aneurysms more than 7 mm with life expectancy of more than 12 years should be treated. Aneurysms of more than 5 mm in young and middle-aged patients should be treated. If the patient has had a subarachnoid hemorrhage from other aneurysm, or if the aneurysm is symptomatic or growing, then these are the kind of patients who should be treated. Smoking, hypertension, and positive family history also add to the risk. And international group of 69 specialists have sort of given a comprehensive guide to which are the patients and which are the aneurysms which should be treated. So basically, these are the AHA recommendations. Patients with unruptured intracranial aneurysms who are considered for treatment should be fully informed about the risks and benefits of both endovascular and microsurgical clipping. This is class 1, level B evidence. And endovascular coiling is associated with the reduction in procedural morbidity and mortality over surgical clipping, but has an overall higher incidence of recurrence. So this is class 2B, level again B. So it is our duty, if we are going to treat these unruptured aneurysms, to make these patients fully aware of the advantages of surgery versus endovascular, or endovascular versus surgery, the risk of recanalization, the risk of rebleeding. So the 6 independent factors are aneurysm size, aneurysm location, prior rupture, age, arterial hypertension, and which part of the world they are from. The question is about what happens if you get a patient who has an unruptured aneurysm and needs thrombolysis. Should you do it or should you not do it? I think Matthew has a case to highlight that. Antiplatelets, anticoagulants, prophylactic aspirin and prophylactic statin. It is believed that the aneurysm ruptures when there is some inflammation there. So to prevent the inflammation, some people have suggested aspirin, and there is a trial about aspirin, but I don't think they really concluded anything. Prophylactic statin also has been suggested, but it has not been used. Of course, blood pressure should be controlled. Smoking and alcohol and drugs should be given up. The question is about weightlifting. Should you allow these patients to lift weights or not? I think mild weights are allowed, and especially non-weight exercises should be encouraged. So let's talk about aneurysm treatment, endovascular treatment. So when we started with the endovascular treatment in the 80s and 90s, we were only treating giant aneurysms, large aneurysms which could not be treated by surgery or which carried a high morbidity and mortality after surgery. So there it was thought that the heat generated when detaching the coil promotes thrombosis, and therefore these aneurysms disappear. But it was realized very soon that they don't work. And smaller aneurysms were being treated, and various methods were used. So we added balloons. The aim of the aneurysm treatment when we treat small aneurysms is to pack the aneurysm as tightly as possible. But even if we pack as tightly as possible, we only occupy 55% of the volume of the aneurysm. 45% is clot. It was expected that this clot would shrink and the aneurysm would shrink over the coils and the neck would get endothelialized. But it doesn't happen, because if the neck is not endothelialized, then the chance of recurrence is very high. So you have to follow up. So to determine the residual aneurysm, the Raymond-Roy classification was introduced. This is class 1, where there is complete coiling. In class 2, there is a residual neck. In class 3A, there is some residual filling of the neck of the aneurysm. And in class 3B, it's the sac which is filling. So in 3A also a part of the sac is filling, and in 3B a larger part of the sac is filling. So if you see this, then you retreat. If you see 3B or not so much 3A but 3B recanalization, then these should be treated. Class 2 does not need to be retreated. So this is with recanalization. But some aneurysms actually grow. And from time to time, we have seen that aneurysms grow. So when we treat an aneurysm endovascularly, it is incumbent upon us to follow up. 3 months, 6 months, 1 year, and annually, we do clinical radiological, plain X-rays. Even plain X-rays sometimes are enough, because they show you the change in configuration of the coil. Your coil mass, if it is the same, after 5 years it is the same. It means the aneurysm is cured. But if the coil mass looks different, then it is probably recanalized. Contrast MRI, and DSA ideally with 3D RA, because sometimes you just cannot make out what is happening. So 3D RA is important. In a different plane, you may see that the aneurysm is recanalized. So because recurrence was high, stents were added. In fact, the first neuroform was deployed by Dr. Uday Lima and myself in 2002. The neuroform stents were used by us. And so now stents were added as a routine to get better results. But then the patients had to be given antiplatelets. And there were closed cell and open cell designs which had their own problems. And coil prolapse through the stent interstices has also been reported in the open cell design. But endothelialization of the neck was still a problem. As Dr. Nasi just showed us, giant aneurysm we still don't know much about. So giant and fusiform aneurysms are still a problem. So parent artery occlusion, which he finally showed in his patient, is sometimes the best alternative for these. So the FD, the flow diverter stent, was introduced as a panacea for the giant aneurysms and even for small aneurysms. Initially only the proximal aneurysms were treated, those below the PCOM. The delivery system was more difficult. You had to pull, push, pull, push. Now it is very easy. The FDs have got better and better. And because we still had some problems with double antiplatelet, coating has been added so that you can reduce the dose of antiplatelet. And to evaluate what is the outcome, there is this O'Kelly-Maruta class scale for FD outcome. So in A, we look at the arterial phase and the capillary phase and the venous phase. So there is persistent of contrast in the capillary and venous phases, then it is phase D. If there is only a partial filling of the aneurysm, then it is B, which persists late into the venous phase. And in C, it is just at the neck. There is some residual filling at the neck into the venous phase. And in D, which is what we all hope to get, where there is complete endothelialization, there is no contrast going into the aneurysm at all. So when there is healing, you will see a line of endothelium along the neck of the aneurysm. Bifurcation aneurysms have always been a problem. And for those, we have now got these flow disruptors, as they are called. And there are three devices: the single or dual chambered web, the contour, and the neck stent. And to evaluate the outcome of these also, there is a Raymond classification. In Raymond, this is a complete cure where the neck is endothelialized. In class 2, there is a residual filling of the neck. And in class 3, there is a residual filling of the sac itself. So the device has got compressed into the aneurysm sac. So the ideal result outcome is A, where there is a complete obliteration of the aneurysm and the neck is endothelialized.
Sir, you have 2 more minutes, sir.
Oh, okay. I think conservative treatment is a very good option for aneurysms which are less than 5 mm, where there is none of the high risk like non-hypertensive, non-diabetic, non-smoker, non-drug addict, and we can follow up. And we have to follow up this. If there is any change in the shape or size of the aneurysm, we have to treat. In a young patient, as I said, posterior circulation aneurysms, one should be more aggressive because these are prone to bleed more often. And larger than 7 mm to 12 mm, there is a dispute: should you treat, should you not treat, how should you treat? Today, I think bifurcation aneurysms are best treated by one of these intrasaccular devices. But we have papers about other things also, flow diverters in bifurcation aneurysm balloons. And over 70, the risk of hemorrhage is higher. So I think, depending on also the life expectancy, these aneurysms should also be treated. When we do giant aneurysms, we always evaluate the cross flow. I'll just show you some examples. This is a patient who had 3 aneurysms. We had coiled her, and at follow-up, you can see that the coil configuration has not changed. So even this aneurysm, you can assume, is cured. We had another similar patient, 2 aneurysms stayed like this, 1 recanalized. The coils got compacted. This is a patient I've treated almost 25 years ago with a balloon, and this one again, the coil mass remains unchanged for years. This is a tiny aneurysm. So for a tiny aneurysm like this one also, if you want to get a good result, you use a balloon which bulges into the aneurysm, and you can get a tight pack like that. So this patient we've treated about 15 years ago, and I've just seen him a few days ago. He's perfectly, the coil remains the same. This is one of Uday's cases, which Uday had lent to me. A bilateral, you can see the tiny MCA, left MCA branch which had to be preserved. This is a patient of stent-assisted coiling. You can see in all these patients the coil mass is quite compact. So the coils have to be compact to get a good result. This is a patient actually I had treated with coils, I think 20 years ago, who came back with a massive recurrence. And here we used a Y stent, and so I don't know whether you can see the Y stent, but today we would use a flow disruptor. We would use a contour or a web. This patient, of course, has a giant aneurysm, one of the few where we have used a covered stent. Covered stent is more stiff and difficult to deploy. This is a giant aneurysm, the typical outcome that you get with a flow diverter. So in such a patient, at least our practice has been to give them steroids for about 3 weeks post-procedure, and to give a new patch, which is diclofenac, which they apply for 2 months. This patient had a complete 6-nerve palsy which completely recovered. Parent artery occlusion or flow reversal. Flow reversal is something which we are doing very rarely today, but which can be very effective. So this is a giant aneurysm, and we've done a proximal artery. We of course check cross flow. We do a balloon test occlusion, and then we do cross flow. And this is a patient who had mass effect from this aneurysm, and we found that she had excellent retrograde flow. So we first did a test occlusion. We kept a balloon at the basilar origin. We injected into the vertebral. You can see both the picas are quite robust. And from the carotids, there was very good retrograde flow. So we occluded the vertebral arteries distally with a balloon in the basilar origin. And this aneurysm gradually shrank. She also had come with signs of brainstem compression, which were relieved over time. What we really do not have an answer for are these fusiform, large, partially thrombosed or largely thrombosed, giant dissecting aneurysms of the basilar artery. We've had good results, we've had bad results. And the problems are manifold. Mass effect on the brainstem, partially thrombosed, so embolism from the part of the thrombosed segment, small vessel occlusion, small influx in the brainstem, compression of the fourth ventricle and aqueduct, hydrocephalus. So some of these patients have all these problems, and we really do not have a solution to these giant basilar artery aneurysms, fusiform dissecting aneurysms. We have tried, like I said, we had excellent results, we've had some bad results. So to conclude, unruptured aneurysms, symptomatic, must be treated. Symptomatic are because of mass effect or whatever. Unruptured aneurysms larger than 10 mm must be treated, that is what I believe. And if we are treating an aneurysm which is intracranial above the ophthalmic, more than 10 mm in diameter, in addition to flow diverter, we should add coils because there is a risk of hemorrhage into it. One thing I forgot to add was to check on whether an aneurysm is active or not. Some people have said you do a contrast MRA. But in addition to the regular contrast, you can use another biological contrast which has been added, which is supposed to be a better, gives a better pickup of activity within the aneurysm. So giant aneurysm, single, multiple LVDs, or finally parent artery occlusion with or without bypass. Thank you.
Thank you, sir.
Thank you, sir, for sharing your 4 decades of experience with us. I just have a small question. What is the bottom line? What is the message that you would like to give to our junior colleagues? Whenever we see an aneurysm, for example, we heard about the size, 5 mm versus 10 mm. Now, this criteria will hold true for all locations, or for example, if you are at the ACOM, you will treat even a 3 mm, or you will not treat even a 4 mm or 5 mm. So just the gut feeling, so as to when you see an aneurysm, what exactly has to be done? A distillation of your experience, please.
I think that's a very difficult question to answer, but let me make an effort. I think posterior circulation aneurysms are more prone to bleed. They should be treated, even if it is small. I was surprised to read in some papers that they have got more cases of MCA rupture, but actually almost everyone agrees that is the ACOM with ruptures. So I have many patients with paraophthalmic aneurysms, with even ACA, antecerebral artery aneurysms. So what I look at is the aneurysm small, and is the aneurysm round, is it smooth walled? If it is small, round, smooth walled, I just follow up. If there is any change in shape, if there is some doubt, always do a 3D rotation angiography, because 3D rotation angiography may show you a little nubbin which you may not see on a CT angio or an MR angio. So at least that's what I do. If it is doubtful that it may rupture, then we treat. But otherwise, if the aneurysm is smooth and round, less than 5 mm, we follow up.
Thank
Any
you so
questions
much,
from
sir.
the audience?
I think we'll move on to the next speaker.
I think we just have one more. It's okay. Fine, we'll take it in the tea break. Fine.